So I'm here today with Mike Klevens. He is the medical director of emergency medicine at St. Luke's Hospital in Chesterfield, Missouri. St. Luke's is a tertiary hospital, about 31,000 visits per year. The majority, he tells me, are over the age of 62. But Mike, do you really see older adults?
I really see older adults. Currently today, we're seeing a 92-year-old, a 90-year-old, two 76-year-olds, and an 88-year-old. And there's nobody under the age of 45 currently.
Well, that's geriatrics for sure.
Yes.
So you and I have been in St. Louis. You're from St. Louis. I moved here 13 years ago, and we've talked a lot of geriatrics. You know, that's my passion. What do you see as the key challenges for community hospitals to effectively and efficiently provide emergency care for aging adults in the near future?
Well, I think understanding the needs of aging adults is the key issue. I think most hospitals have gotten by with just treating people as people and not sub-segmenting them into specific need populations. So the geriatric adult needs different things than a middle-aged adult that needs different things than a younger adult. We've always said that people are either pediatric or they're adults. And for a long time, it was said pediatrics is just not little adults. Well, the same thing applies to geriatric patients. They're just not older adults. They require so much more effort, education, facilities, but it's a matter of educating.
Yeah, that's a good point. There's nothing that we're doing that's saying that they're a more important population, right? Or that we should be spending more money, more resources on them, just that they're different. And if we don't recognize those differences and manage them efficiently, it's going to hurt all the other populations that we're trying to take care of, because we're not going to be efficient in caring for older adults. One criticism, as one of the authors of the Geriatric ED Guidelines, accepted and endorsed by the American College of Emergency Physicians and the Society of Academic Emergency Medicine and the American Geriatric Society, one of the criticisms is that they can only realistically be applied to large academic hospitals. I've heard that many, many times. Another criticism that I've heard from Peter Rosen, who just co-authored a textbook with me on geriatric emergencies, is that we're destroying the original vision of emergency medicine, which was to take care of anyone, any place, any time, by sub-segmenting it into the different venues: a pediatric hospital, a stroke hospital, a cardiac hospital. I think that I'm disappointed in the name that we chose for geriatric ED guidelines, because it implies that every ED should build a separate space for older adults. On the contrary, we actually state right in the guidelines that with implementation of the following recommendations, hospitals, regardless of size, will positively impact the care of the geriatric emergency medicine patient. And then we had an accompanying executive summary that went along with that said that the geriatric ED guidelines represent recommendations for older adult emergency care, not a mandate for every geriatric-friendly ED to develop and sustain all of these elements. Instead, the principles should be tailored for each ED according to patient needs and available resources. Do you think that these guidelines only apply to large academic centers, or can components of the guidelines be used in every ED that serves older adults during times of emergency?
Well, I think the word guideline has always been the issue. So what is a guideline? So a guideline has often been used by our stroke counterparts to when, for example, to give TPA, and then it becomes a mandate. The word guideline may be misconstrued by people that says that this is a mandate. Well, it's not a mandate. What it is really, how do you educate? How do you create transitions of care? How do you create education, quality improvement programs, equipment, and supplies? So really it is, how do you purpose what you already have into accomplishing the three segments of population, I'll call it, for your own emergency department. You do not have to have a freestanding emergency department for geriatrics. Mm-hmm. You do not have to have a freestanding emergency department for pediatrics. It's how can you have, as Peter Rosen says, every emergency come in and be treated correctly. So the right place, the right medication, the right time, the right education. And I think through those guidelines, the education of the providers, nurses, C-suite executives certainly, to learn how to properly treat all of the populations that come into the ED at any one time.
Yeah.
If that makes sense. I mean, what I'm trying to say is it doesn't have to be a freestanding emergency department. We can take portions of the guidelines and put it in our emergency department, for example. Mm-hmm. I have a section of our emergency department that I would love to put into to have a geriatric-friendly area. It's got great lighting. It's got better beds because it's a newer portion of our emergency department. Mm-hmm. The problem is now I have 3/4 of my emergency department are geriatric adults. So I almost have to reverse it.
Yeah. Yeah, I think that that's going to represent the majority of EDs across the country, is that they're going to adapt the entire ED to care for older adults, not have a specific area of the ED that's geriatric specific. Even the hospitals that have developed geriatric specific EDs, like the New Jersey Hospital and Mount Sinai in New York, they often spill out because their geriatric unit fills up so quickly. The geriatric patients flow into the general ED, and so they end up having to geriatricize their entire ED. I think that's going to be the norm, both because of the volumes of patients we're going to be seeing that are older and need geriatric services, and because the lack of resources that we have to have a devoted space just for geriatrics. So I think that's going to be the norm.
There is a theory in design when you design a house. It's called universal design. That your home is going to be friendly for you for the moment you were born to the moment you're in middle age to the moment you die. You have toilets that are raised. You don't necessarily have bars and things like that. The same thing with our emergency department. The idea of a universal design that accommodates everybody, I think, is certainly possible. And accommodating the older adult also allows us to accommodate our middle age and also pediatric population more efficiently as well.
Yeah, I concur. I think the older adults are the canary in the coal mine, and what works well for them is going to work well for other populations. I neglected to mention in your introduction that you've got an MBA as well. You just reminded me of that as you're talking about system design. I think that with the multiple moving parts that we're going to need to pull together to geriatricize EDs everywhere, we're going to need a lot of expertise from C-suite administrator types, from healthcare system design folks, from bedside clinicians and nurses, and from all the people that care for these patients before they get to the ED and after they leave the ED in times of emergency. So I do think that having you on our panel in November with your MBA expertise and the ability to communicate these ideas that the administrators need to hear, it's going to be key for others to learn from.
And I think a lot of it is how we move from fee-for-service to value-based purchasing. Emergency medicine really hasn't hit that sweet spot of what this really means with the MACRA and the MIPS, the next phase of how medicine is going to be paid for. And a lot of that is going to be value. What the proposition here is value. So what value can we bring to our older adults in their care? We have 3 streams of people coming into the emergency department. People who are going to need to be observed, people who are going to need to be admitted, and then there's a group that needs to go home, okay, who doesn't need to stay in the hospital. Our most vulnerable population is that 90-year-old who doesn't need to come in the hospital, doesn't need to be observed, but can't go home. Mm-hmm. And so what am I going to do as a physician do about that? So I need heavy social services involvement. I'm going to need heavy care management involvement, and then to be able to move people from the emergency department to a nursing home or to an extended care facility without the worry that they're going to have to pay solely out of pocket. Because it used to be we could admit those people for 3 nights. Now there's a rule coming down in January that says we might be able to observe people for 2 nights, and that will count towards their stay towards a SNF. But that's still in legislation. I'm not sure that that's going to be fully passed.
Okay. Well, I look forward to hearing more about that in November. Speaking of the guidelines from ASAP, have any of these recommendations permeated into your ED at St. Luke's?
Well, I think the parts that have, for us, permeated is our social services. We have started to develop a more integrated social services staff for older adults, and that's going to be the key. We have our own nursing home, so we do own a nursing home in our system, and being able to get people from our emergency department to our nursing home is slowly getting to be an easier task. We also have some bridges to some assisted living facilities. And having somebody come down along with our palliative care group, we are ramping up our palliative care group very fast, and that palliative care group is going to be very important in pulling people away from some of the financial burden that is being thrust upon us by the government.
So how do you operationalize protocols with palliative care and with the nursing home populations? Do you have regular meetings with their medical directors, or how do you put systems in place in the ED to make sure there's smooth transitions?
So it's a very long and challenging process, and I would not say that we're even close to something smooth just yet. We meet often. We've recently had what I call a bipartisan committee of social work, medical professionals, as well as case managers to talk about our frequent elderly flyers, people who are at home, coming to the ED for services, being observed, sent home back to their facility, and then failing that facility and then coming back but still not qualifying to be in an upgraded level of care. And we're trying to figure out the best way to do that. And it's going to be for us to expand our home services element of our hospital. And that's, for us, our next target. And it's a long process because nobody wants to really embrace this.
Yeah, it's a asymmetric thinking on return on investment, I think, because society hasn't decided that's going to be where we're going to reimburse care. So I think that is going to be an important part of our discussion in November as well. Speaking of the November discussion, which is going to be entitled Senior-Friendly Emergency Care, What Doctors, Nurses, Hospital Administrators, and Ancillary Providers Need to Know. What would you like to see discussed at this symposium?
I think there are a couple different things. The first thing is how do we get the C-suite involved? That's one thing. I don't think the C-suite totally understands. They're faced with a bunch of mandates. Mm-hmm. They have a whole different set of pressures that we don't understand. I think that's first thing. They're being pushed on the financial front, so they need to understand the value proposition of this geriatric care and how that's going to help them in their bottom line. So, how can we help them understand the importance of the need of geriatric care? That's for starters. I'd also want to hear about what is the best practice of how to accomplish getting the guidelines in place. I know you have the geriatric boot camp, and the geriatric boot camp is important. And you can even bring the geriatric boot camp to your own hospital. But I'd like to know what is the best practice of how to alter staffing, how to have geriatric policies and procedures that can be universally applied without creating strain on the system.
Okay. Well, excellent. Well, I do hope that we can deliver all of that and more in November. Mike, any thoughts for the audience before we say goodbye?
Well, I think when people think about geriatric care, they have to understand that this is just the tip of the iceberg, what they're seeing right now. When you look at an iceberg, you see only the top. You don't see the bottom. The bottom is yet to come. We are nowhere even near what is about to hit us. There was a pictogram that I saw of a tsunami. This is a wave of demographics that are going to hit us not once, not twice, but the wave is going to keep going over and over us for the next 20 to 30 years. And the elderly are not always sick. The elderly are well. Some of the elderly are well right now, and they've got about 20 more years, and they're then going to get sick. So we have a long road ahead of us in terms of caring for folks.
Yeah. So it behooves us to plan ahead, for sure.
Absolutely.
Okay. Well, thank you for chatting with me today, Mike, and look forward to hearing much more in November.
Sounds good, Chris. Thanks for having me.